Good afternoon, everyone, and welcome to this CME on the diabetes foot. It's a great pleasure to have all of you over here and multidisciplinary teams associated with the management of the diabetes foot. Today, before we start our CME, we have to describe the relevance of this entire problem. It is a perplexing problem which encompasses the entire world. It's an area which is faced with much neglect, and it's also a cross-disciplinary issue that we need to be concerned about over here. Now, one of the things and the mandates of CMC Vellore, of course, is reaching out to the unreached. And we have a vast network of mission hospitals. Diabetes is no stranger in those areas, and the diabetes foot is a huge problem. For the occasion, we have none other than Professor Jachin Velavan. Jachin is Associate Director of Missions and has a very impressive curriculum vitae which skirts the development of the distance education unit. So she is primarily involved in the development of this unit, which now covers the whole of India and a number of neighboring countries in training people with many areas. The Department of Endocrinology was the second department after the family medicine department to start a training program in diabetes, and we have trained more than 900 doctors and perhaps more than several thousand nurses in this aspect as well. They have several courses in geriatrics, psychiatry, and many others. So, Jachin, I hope you're there. And
okay. Good afternoon, and I hope that you can hear me. I'm really sad I could not join you in person, but I'm so delighted to be part of this starting of this very, very important thing, on the diabetic foot care. And this hybrid program is something that can really, really increase the reach. As Dr. Nihal already explained the reach of these things and the need for this, the thing that excites me is the reach that this can actually take diabetes foot care to. I'm a family physician, and I know that how much of diabetes foot care is needed at the primary care level. And the thing that is most needed is the proper understanding and training on these things. So I'm delighted that the Department of Endocrinology has taken this to another level of doing this series of things along with the NNF and all the partners. And I'm also very delighted that each of you are part of this journey with us. So I just want to say thank you for joining us. And I do believe that this will make a big difference to the diabetes care, especially with related to foot and all its related complications across the nation and in other countries as well. So I wish each of you the very best, and the department the very, very best, both from the distance education side and also from the directorate. On behalf of the director and all the administrators, want to wish you all the very best. Thank you very much.
Thank you. I'd like to introduce the chairpersons for this particular CME, and I would invite them to come on board. Dr. Nihal Thomas, Head of the Department of Surgery, Unit 1, would you like to come forward? Thank you. Professor Bobina Chandi, Professor in Physical Medicine and Rehabilitation, and Professor Shashank, who's the Head of the Unit of Plastic Surgery. Welcome. Let's give them a big hand. Surgeons spend only 1/3 of their time in a sphere which is familiar to us. And so we're really honored to have all of you. Bobina, I might call you a surgeon for the time being, and despite your busy schedule. Thank you so much for joining us, and we have the best of the best to chair this particular session. So let me introduce our guest of honor for today, and it's a real privilege to have you amongst us, sir. So we have Dr. Zulfiqarali Abbas, who is an endocrinologist and diabetologist in Dar es Salaam in Tanzania. He is involved in the area of diabetes foot and he's dedicated his life towards it for the last 30 years. So I would probably like to say that besides the number of fellowships he has been awarded, he is currently the president of Diabetes Foot International. He's also the founder and the chairman of this particular organization, which helps in the dissemination of proper management of the diabetes foot. There's a huge focus on primary prevention of these diseases, and especially in less developed countries and least developed countries, this is a major issue in terms of primary prevention and secondary prevention of this disorder. So as I mentioned, he's the founder. He's also a founder member of the Diabetes Foot Study Group of the European Association of Study for Diabetes, the AST, and is a founder member for several committees in Africa in addition. He has published extensively on the epidemiology of this particular condition, and he is the first to characterize the burden. A lot of what he does stands for what CMC Vellore is, in the sense that whatever he has put into practice as a physician, he has tried to reach out to the unreached. And of course, the continent of Africa, the West, the East, all parts of Africa really need this kind of a person who has developed multiple programs. And in my talking with him, he has developed this program to cover 80 countries. Correct me if I'm wrong, 80 countries across the world. It might be more. And several people have been trained in primary prevention of this. He has received the Carol Baker Diabetic Foot Award of Honor for outstanding contribution to diabetic foot care and the 8th Symposium, the Diabetes Foot. Ladies and gentlemen, let's give him a hand for the same. And received the Lifetime Achievement Award, Honor, and the World Union of Wound Healing Sciences in 2022. So amongst all these, he has, of course, made several visits to India in the past, but this is his first visit to Vellore, and I do believe this is the smallest city that he has visited in Vellore. Thank you for coming to our humble abode. Dr. Abbas, over to you. Thank you so much. I would also like to mention that if in case you have difficulty understanding English, Dr. Abbas can also speak in Hindi. So thank you.
Once again, thank you very much, Professor Nihal, for a kind introduction. My today's talk is insight into the guidelines for infection and the diabetic foot according to the International Working Group on Diabetic Foot. Before I start my talk, I would like to thank all of you from Christian Medical College Vellore and all the organizers who've been working behind this for this seminar. And special thanks to Professor Nihal and Professor Felix, who actually instrumented all this thing and invited. Thank you very much. I come from Dar es Salaam, Tanzania, which is the east coast of Africa. It's the length of Mount Kilimanjaro, the greatest, the biggest Ngorongoro crater in the world, the largest game park in the world, Serengeti Park, and Zanzibar Stone Town. So you are all welcome if chance comes to you. Today, this is an international working group of diabetic foot. This was a group of 12 people, which we wrote international consensus 2015 to 2019. And these were the 12 people who wrote in last 4 years. And this has been revised again, and now we are 14. 4 of them, 2 left, and 4 of them came from Infectious Disease Society of America. And these are the papers already on PubMed and Medline, which were released on 13th of May, this international consensus, as I said here, 13th of May this year, and it's already out for you to go and do the survey. Now, International Working Group of Diabetic Foot, past 4 years, every 4 years, they come up with new guidelines how to go about with treating diabetic foot in all aspects. So we follow the GRADE system, which is grading, recommendation, assessment, development, and evaluation framework, which is used for these guidelines. And this tool provides the rating and the quality of evidence for the systemic review, which we do, and clinical guidelines. These structures usually identify the key questions around PECO, which is population, assessment, comparison and outcomes of the papers, and patients, PICO, patients, populations, intervention, comparison, outcome format. So this is the format we run, and then what we do is we determine the patient's importance outcomes, presenting the evidence which we have, assess the certainty of that evidence. So we look into whether what certainty evidence is there at the level. Finally, we move to the evidence of recommendation. The editorial board appoints a multidiscipline to update previously published to the new. So we reviewed about 14,000 papers in last 4 years. That's why I started 15 to 19. And then we added other new papers in next 4 years. So every person had about 1,200 papers to review. And then we do all this process going through the voting system and what to go and about. It takes a lot of hard work to do and intensively in last 2 years. So strength of each recommendation is rated whether it is strong or conditional. So this comes from a board, this group, International Working Group. And then the evidence, certainty of evidence comes from the literature review and scoring. So whether that paper has got a high score, moderate, low, or very low, and that's how it goes. So at the end of the 4 years, we gave 25 recommendations in this infectious group. And there are many other groups do the same way. So let's see what is the natural history of diabetes-related foot ulcers. So this is now a new term which has started this year in May. We don't call it anymore diabetic foot. It's been diabetes-related foot ulcers. Natural history, where you have a normal diabetes foot, then it goes to the high-risk foot, peripheral neuropathy or arterial disease. Then it becomes ulcerated, sustain an ulcer. The ulcer becomes infected. And that's where we are going to focus today, not the rest of the things. So our focus would be on infection. Infection leads to necrotic foot, and then necrotic foot, it can completely heal where the surgeons intervene, or it might end up with amputation, or we might lose the patient. So the burden of diabetes-related foot infection is high, and especially in our part of the world. Foot infections are common, complex, and serious problems, especially in low, middle-income countries. Is always associated with underlying PN or PAD. 85% of diabetes-related lower limb amputations are preceded by foot ulcers, and 25 to 50% wherever you are in the world ended up with immediate amputation due to infection. So I'm going to go through this recommendation with a real-time patient. This is our patient, and you might see him when you go back tomorrow to work. So this is a patient has come to the clinic. What should we do for this patient? So the first thing is, what are the risk factors in these patients? Why he or she got this an ulcer? So could it be peripheral neuropathy, arterial disease? And nowadays, mostly we see in most of the part is neuroischemic lesions with both peripheral and peripheral neuropathy and arterial disease are there. Then you have to risk categorize it, whether it's a zero category where there is no PN or PAD, or there is only peripheral neuropathy, no PAD, or both PN, PAD, and deformity, or there is a history of previous ulcers or amputation. So that's how you grade it from 0 to 3. Is this lesion infected? Obviously, everybody in this room will agree with me. Yes, it is infected, and you can see it's infected. So what are the recommendations if the lesion is infected? Diagnose a soft tissue diabetes-related infection, foot-related infection, clinically based on the presence of local and systemic symptoms of infection. Here, the recommendation is very strong, but evidence, certainty of evidence is low. Assess the severity of any diabetes-related foot infection through the classification system, which has been shown by us International Working Group or Infectious Disease of Society of America. And the recommendation is strong, but evidence is low. So classifying the severity, obviously we have to obtain the history, ask about fevers, chills, rigors, night sweats, all these things which we learn when we are undergraduates. And one thing which we all forget, and that's a tendency of human nature, usually we have to examine the patient as a whole, not only whole in the patient. So the focus, especially our colleagues, in most of the cases, we concentrate on the whole in the patient and we forget other metabolic disarrangement or septicemia and all these things. So you have to examine the patient as a whole. Clinical characteristic of serious, it could be wound specific, tissue involvement or local signs. And all of you are aware of this: redness, induration, tender, warm, lymphangitis, or it could be severe, generally systemic septicemia or severe metabolic derangements. And this is the classification which has been proposed in international consensus infectious group. So if you have a grade 1, which is non-infected, where there is no signs of infections locally, only ulcer, or superficial tissue lesion, at least 2 of them has to be there. So to have a grade 2, which is mild infection, local warm, local tenderness, pain, local swelling or indurations, erythema of more than 0.5 to less than 2 centimeters around the ulcers, prolonged discharge, and other causes of inflammation has to be. This erythema of more than 0.5 to 2 centimeter, it's usually, we see more than 99% of them, we see more than that. So it's been taking consideration of global, even the Western world. When you come to the grade 3, moderate, the erythema more than 2 centimeters, and one of the above findings which I mentioned here out of 4, or involving the deeper structures, involving the bone osteomyelitis or arthritis or fasciitis. Now here, if the bone is involved, then we put into the bracket grade 3 moderate infection with 0, that is with O, that is osteomyelitis. And I have put another in the bracket, that's for my local national thing I've added for my people, is that when they see a patient in this category, infection grade 3 moderate, then they should refer to the highest center if they are at the primary or health center or a district level and they cannot manage it. It has to go to the regional or referral hospital. Recommendation 2, consider hospitalization. When should we hospitalize the patient? So consider hospitalization if there is a severe foot infection, which I'm going to show you what is the classification of severe foot infection, or if it is a moderately infected, then with comorbidities. And here the recommendation is conditional and evidence is low. So severe infection, that is grade 4, and here we all know that temperature, and at least 2 of them should be there. Temperature is fluctuation in diabetes patients, could be more than 38 degrees or 30 less than. Pulse rates high, respiratory rate high, white cell count can be high or low, misleading, or 10% immature leukocyte with bone involvement could be there. So if a patient is in septicemia or metabolic dearrangement, that is a severe and has to be hospitalized. Osteomyelitis could be there or not, so we can add 0 plus minus and refer to the patients, do not delay. That is the fast track pathway if they cannot treat the patient. 3 most important clinical categories of infections are known by all of us: cellulitis, which is the least infections; deep soft tissue infections, where fascia and muscles are involved, or when the bone is involved, it is osteomyelitis. Cellulitis is most common, characterized by erythema, swelling, heat, or lymphangitis, and surgical intervention usually is not needed here. Medical personnel can treat this patient. And this was a patient due to the callus, which has got infection because of Muslim patients praying on that position. Then we have a soft tissue infection, deep soft tissue infection. It involves a deeper structure. If we delay here, necrotizing fasciitis, which we are going to hear now, could be life-threatening, and debridement would be definitely a life-saving here. So surgeon involvement is utmost important here. Osteomyelitis is always a spectrum of haunting management of diabetic foot ulcers. Both laymen and healthcare workers are in a dilemma. But osteomyelitis is one of the end stage to the path of amputation, but it is not an indication of amputation. Commonly found in 20% overall infections, that's what literature says, and it is severe, more than 60% have already involved born in diabetic foot infections. Usually, underlying ulcers may not be infected. Morbidity is highly associated with recurrent infections, hospitalization, and lower limb amputation can go, according to the literature, 23 times higher in these patients. But there is a polymicrobial microbiology, if you say, and all is a bags of worms. Coming back to our patient, how did it get infected? And we all know there could be a risk factor leading to abrasions or trauma or whatever, and that led to an infection. Should I culture the wound? Yes, everybody would agree that. So we are in the consulting room and we are thinking about this. Should I culture the wound? Yes. If I have to culture, how should I obtain the specimen from this patient? So let's see. Recommendation 5. In a person with suspected soft tissue related infection, culture, deep tissue biopsy is must to be taken from the wound, and the recommendation is conditioned, but certainty of literature shows moderately high. Proper culture is usually advisable after the wound has been debrided, and you need to take a deep tissue biopsy. Here, the pus swab will not help. Pus swab will only help if it is a cellulitis, and if you want to take an aspirate, that's where it will help. That's a recommendation. When the swab's only option, then clean the best and take the swab. Consider obtaining the blood culture if the patient is septicemic, or bone culture where there is a suspicious of osteomyelitis. Recommendation 5 says the same continuation. If we, in low middle income countries, we do not have a facilities of cultures, and most of the time in our part of the world, it's only in the referral hospital, then all is gold. Gram smear, gram staining is the best for diabetic foot infection and could be relatively easy and inexpensive. Me and Professor Nihal were doing these things when we were doing internship, maybe early 80s or something like that. 80s. We had a bed, every ward had a bed at the corner where you used to take culture and do gram staining, but it is forgotten. So this is right, and that was a recommendation condition, but certainty was high, and it was put into the international consensus. This was a paper which came from our center to determine the utility of gram staining versus culture in guiding the antimicrobial therapy for infected limb ulcers. And there was no significant difference. Predicted value was positive for gram staining, equally to the culture and sensitivity, about 93%. So we showed that in the region with limited microbiology resources, gram staining alone of deep tissue biopsy, not the swab, is largely predictable of underlying infection, microorganism, and routine gram stainings are much cheaper and sustainable than culture, which are difficult in our part of the world. So moreover, we established that the management of diabetic foot ulcers should include at least gram staining and not a swab. Broad spectrum antibiotics should be started covering both gram positive and negative pathogens. In this cohort, prospective cohort, we neither had mycobacterial or HIV patient in our cohort, prospective cohort, because to avoid the bias, we tested them all, and there could be a bias element showing that maybe playing some pathogenesis in this population. Okay, coming back to our patient again, we have reached rectal layer. So what are the likely pathogens? Now the culture has already been taken. Microbiology diagnosis usually assist in the management of diabetic foot ulcers. Chronic infection or lesion in patients who have received prior antibiotic, and it's common in low and middle income country because they've already done a shopping around, are usually polymicrobials. In wounds with necrotic tissue, anaerobes are often present in large numbers, and when the wound has been soft, then Pseudomonas is commonly there. Are any surgical procedure needed? Yes, everybody would agree in our room, we will need a surgeon here. And how do I diagnose or treat osteomyelitis? So following are used as an initial test to diagnose osteomyelitis in person with diabetes. Consider probe to bone. So you will hear the grading of the bone once you do with probing to the bone. Plan X-ray will show this was a pathological fracture set on this for I don't know how many months, and it was been only cleaned superficially. And then you can do the blood test, ESR, C-reactive protein, or procalcitonin. And the recommendation 7 says the same thing, that in person with diabetes, use a combination of probe to bone test, plan X-ray, or any of the blood tests as an initial study of diagnosis of osteomyelitis. And here the recommendation is conditional and evidence is low. Recommendation 8 says MRI can be used in a doubtful situation, clinically, or plain X-ray or blood test. Recommendation is strong here with moderate evidence from the literature. But as we all know, this is not possible. So depending on patient setting, advanced imaging of diagnostic osteomyelitis is not needed in most of our patients. And actually in our part of the world, clinical is the best we can guide that. Recommendation 10 says, in a person whom there is a suspicious of osteomyelitis of the foot before or even after the treatment, then bone culture should be taken. Here the recommendation was conditional, but evidence has shown moderate. Should I prescribe antibiotic to my patient? Obviously in this patient, we will all say yes, and then I'll come later on. But recommendation 11 says, clinically, if the foot ulcers are not infected, systemic and local antibiotic should not be the goal to reduce the risk of infection, or usually we have a infusion that it promotes ulcer healing. This is a best practice statement. What antibiotic, if we have to start, should I start? And how should I modify the therapy if we go along later? So general principle is empirical choice. Initially empirical broad spectrum based on clinical or lab data. We can start a broad spectrum, always cover both staph and staphylococcal, consider common leukocytes in that local area, or with antibiotic sensitivity already done. Broad spectrum is necessary based on clinical condition, clinical pictures, or previously the cultures have been shown there, or the gram stain smear results. So recommendation 12A, and there are 4 here, use any of the systemic antibiotic regime which has been shown effectively in published randomized controlled trial locally, or what is known, those to treat a person with diabetes and soft tissue infection. Here the recommendations are strong and it is highly evidence in the literature. General principle, once we have received the culture report, then narrow the broad spectrum spectrum of therapy, antibiotic therapy. So select an antibiotic agent for treat a diabetes-related foot infection, likely or proven the causative. So the culture results are already there, and the susceptibility. That's a best practice statement. 14 recommendation is anaerobe gram-positive pathogens only for people with mild diabetes-related foot infections who have not recently received antibiotic and who live in a temperate climate. So you give it a target only gram-positive pathogens in temperate climate with mild diabetes foot infection. But in recommendation 15, do not empirically target antibiotic therapy for Pseudomonas infection with diabetes-related foot infection in temperate climate, or isolated cultures have not shown Pseudomonas. But in severe infections living in tropical and subtropical country, you can start. These are the list of proposed empirical antibiotic therapy, and they are all there on the website. We cannot go to detail because of time limit. So this is the mild ones, the moderate and severe, how to go about. And what are the route of therapy, antibiotic? Tropical, very few data. You can hardly see 3 or 4, maybe 5 papers published on tropical application for mild superficial infection, and it has not been studied adequately. This is a widely open to do a research here. It is really very gray area. So overall, orally well supported for most mild to moderate infection, but if there is a GI problem, then that is not appropriate and we have to go parenteral therapy. At least in severe infection, it should be started initially. Where no appropriate oral agents, you can start, or if a patient is not stable, vomiting or something GI problem, then it can be started. How long should I treat this patient? So we are still in consulting room. How long should we treat this patient? So recommendation 12B says, administrate antibiotic therapy to a patient with soft skin and soft tissue infection for duration of 1 to 2 weeks. And recommendation from a group is strong with evidence in the literature high. 12C, if after treating 3 to 4 weeks and still the improvement is not showing the resolving, then expect, or if the patient has severely peripheral artery disease, then we have to go redo all the diagnostic tests. If evidence of infection has not resolved 4 weeks of appropriate therapy, then re-evaluate the patient. That's 12D, further diagnostic study and alternative treatment. Here the recommendation is strong, but evidence in the literature is low. Patient with duration of antibiotic for 3 weeks if the amputation has been conducted, minor amputations. But if the amputations have not been done with positive bone margin culture, 6 weeks is recommendation. Now this is new. From 12 weeks, it has come to 6 weeks for diabetes-related foot osteomyelitis without bone resection or amputation. Here the condition is low condition, but the evidence is also low in the literature. Recommendation 17, we need to follow up these patients with osteomyelitis with duration of 6 months after the end of antibiotic treatment, and because the chances of remissions are still there, so diabetes-related osteomyelitis with the foot infection, and this is a best practice statement. Recommendation 18 says, urgent surgical consultation should be obtained in severe infection with extensive gangrene, necrotizing fasciitis infection, signs of deep abscess, compartment syndrome, or severe lower limb ischemia. Here we need to be urgent surgical consultation. 18, within 24 to 48 hours, consider performing the combined with antibiotic for moderate to severe diabetes-related infection to remove infected and necrotic tissue if they are there. Here the condition is, the recommendation is conditional and evidence is low. 20, people with diabetes, peripheral arterial disease, and foot ulcers or gangrene with infection involving any portion of the foot obtain an urgent consultation with surgeons and vascular specialists to determine the indication and timing of drainage procedure or revascularization procedure. This is a best practice statement. That is number 20. 22, recommendation 22, it says antibiotic treatment without surgery. So the physician can handle it for foot osteomyelitis without immediate need for intervention or incision drainage or controlled infection, without peripheral arterial disease, and without exposed bone. So here the recommendation is conditional and evidence is low. What should I do for the topical treatment now? So we have talked till from the risk factors, treatment, diagnosis, now topical treatment. So ideally the topical treatment, which dressing to choose, remove the excess exudate and toxic components, maintains the high humidity at the wound, allow the gaseous exchange, provide good thermal insulation, protects from the secondary infection, free of particles or toxic contaminants, so powders and these are not allowed, allow removal without trauma when you change the dressing. Moist wound dressing has been said all the time, 50% faster in rehabilitation in partial thickness of the wound. benefits the most wound healing. Wide variety of new materials are available, such as all this which I mentioned there. But what the recommendation says from international consensus. So recommendation 23, tropical therapy or adjuvant therapy. We suggest not using the following treatment to assess diabetes related, to address diabetes related foot infection. Adjuvant granulocyte colony stimulating factors or tropical antiseptics like silver-based preparation, honey, bacteriophage therapy, negative pressure wound therapy, with or without installations. Here, the board, the foot infection group recommended the conditional, and the literature review is low. We suggest not using sponge, cream, or cement antibiotic in combination with systemic antibiotic for treating either soft tissue or osteomyelitis of the foot in patients with diabetes. Conditional recommendation and literature review certainty is also low. And lastly, recommendation 25, we suggest not using hyperbaric oxygen therapy or tropical oxygen therapy as an adjuvant treatment for solo indication of treating diabetes-related foot infection. This is the recommendation is conditional, and the literature review also shows low. Right. What is the expected outcome in our patients? So we've gone through all these things. So the patient could be completely healed, so we are all happy, or it might end up with minor or major amputation, or we might lose the patient. Whatever I've said, the importance of basic foot care should never be forgotten. Metabolic control, we should not forget. Tight control of glucose is very important, otherwise you will not win the battle. Control of infection, vascular control, definitely surgeons has to be in. Wound control, debridements on frequent basis. This is the forgotten part in most of the part our low and middle income countries. Mechanical control, that's offloading, and prevention is educational control, which I see here is being done very well. So that is what we should never forget in treating diabetic foot infection. Now, these are the key controversy, and still we don't know the answer to it. Whoever it's an open thing. Whoever is interested can go into this and do a research. How and when to determine soft tissue infection and osteomyelitis has resolved. What are the most useful serum biomarkers for osteomyelitis? To what extent can the duration of antibiotic therapy be reduced for soft tissue infection and for osteomyelitis? When and which available advanced imaging study should clinician order for the patient with diabetic foot infection? Thus, using information from a bone biopsy improves the outcome of osteomyelitis, or we are wasting our time, energy, and money. What is the place of new antibiotics in diabetic foot infection? Is there a definition or the concept of chronic biofilm infections of diabetes-related foot ulcers? Does the molecular, it's been talked too much these days, genotype microbiological testing for diabetic foot infection help antibiotic therapy and improve the outcome? What is the potential for topical administration of antibiotics, which is a very, very gray area, and only 3 to 4 or 5 maximum papers for past 8 years we've seen. Antibiotic to limit the use of systemic antibiotic in diabetic foot infection. So in conclusions, efforts are still required to increase the awareness of diabetes and its complications among the healthcare workers and patients. Early detection and treatment of diabetes will improve the course of disease, definitely will reduce a lot of amputation and death in our patient. Lastly, I leave with this slide is that willing is not enough, you must do it. So whatever we have learned here, we must do it. Knowing is not enough, we must start applying once we go to our clinic. Thank you very much.
Next, to enlighten us on early diagnosis of peripheral arterial disease in diabetic foot infections, we have our Professor Prabhu Premkumar from the Department of Vascular Surgery. Over to you, sir.
We all learn something new every day. And today I learned that it's no longer diabetic foot infections, but diabetes related foot. So thank you, Dr. Abbas, for introducing the new term. And welcome to CMC and to Vellore. I hope you have a wonderful experience here. Thanks, Nihal and team, for inviting me here to speak to this quite enlightened audience. It's good to see Anil after a long time. We have been highlighting the value of peripheral arterial disease of late in past few years. Guidelines who have emphasized this in no uncertain terms. Over the next 10 minutes, we'll quickly look at this talk in these few headings. What are we dealing with? Nature of progression, Dr. Abbas has beautifully covered. Pulses, investigations, imaging, management, and the role of a vascular surgeon. 15% of diabetic patients will develop foot ulcers. And major amputation is 5 to 10 times more in diabetics. And once a diabetic patient has an amputation, their longevity is less than 2 years. 50% of them will die within 2 years, both from the physiology of the amputation and progression of disease. For us in vascular surgery, it's become a patient having vascular problem, 9 out of 10 times he is a diabetic. Very, very rarely do we see somebody who's not a diabetic having a vascular problem. With such a large prevalence of diabetic foot ulcer, truly, and India becoming the capital of diabetes, another new term is diabetic foot attack. All of us sitting here have seen this over and over and over again in our wards, in our mission reach hospitals, in our peripheral clinics. Allow me to focus just on the last part of this vascular disease. When we were training, it was thought that vascular disease, diabetes, is a microvascular disease. Fast forward 3 decades, it has become a macrovascular disease. There's an entity now called SAD, small arterial disease, and BAD, which is big arterial disease. And invariably, it is in diabetics. So the natural history, neuropathy, and I agree with Nihal and Professor Abbas and others that neuropathy is where it all starts. With neuropathy comes the ulceration. With ulceration comes the infection. With infection, ischemia sets in. Now, ischemia setting in is because the infection sometimes just overwhelms the disease process. Emmanuel will be speaking after this, and I authored a paper where, despite the best of revascularization, the infection is so profound and we see them so late that even though we have revascularized the patients, a third of them are ending up with amputations. So which means we need to pick this up right from the periphery, right from the GPs, right at the mission hospital in the outreaches, and use the pyramidal model to pick up vascular disease right out there in the community, and then bring it up to the tertiary care and quaternary care levels, not the other way around. In India, we're seeing it the other way around. They come to us when it's far, far too late. In the Western population, one small toe ulcer, one small black dot, they will immediately go to the GP. GP picks it up, sends it straight to the vascular surgeon. In our country, as I'm sure Dr. Abbas will say, they reach us at a point where amputation is a formality. And they've expended their money, their resources by the time they reach us. So here's the crux of this next few minutes is pulses. The key to managing diabetes is to know your pulses. Not the tur dal, nata dal, the masoor dal, but the pulses that God has given us and the blood flowing through our system. So the key question is, why pulses? Why check pulses? What is the big deal? So there are 3 points which are really important. And I can emphasize this for the trainees as well as those who are listening to the mission hospitals and periphery. First is to assess the vascularity. you need to have a vascularized foot for the foot to survive. It also defines which segment of the foot, lower limb, is affected. And the segments are the iotoiliac, the femoropopliteal, and the tibial. Far too often in our country, as is the experience in the Arabian and Africa, is people come to us with tibial disease. It is easily prevented right at the beginning, but people don't check for pulses. And the third and most important thing is, just based on pulses, we are able to see what level of treatment or what treatment is required for these patients. Just pulses. So comes the question, which pulses, doctor, should I check? Femoral, popliteal, posterior tibial, and dorsalis pedis. Please familiarize yourself with these pulses. We have an elegant book called Das. It's also there in Cunningham. It's also there in Bailey and Love, Practice Surgery, just 2 pages. And I will encourage every medical student, every nurse, every professor of vascular surgery or diabetes or any specialty to know how to feel pulses. So let me walk you through next 2 minutes how to check for pulses in the femoral pulse. Patient comfortable, privacy, feel for the anterior superior iliac spine, feel for the pubic tubercle, midway is the femoral pulse. And you're feeling this against the femoral head. All pulses are against a bone. Popliteal pulse, very, very crucial pulse. Patient comfortable, leg flexed, knee flexed. Make sure that the calf muscles are nice and soft, they're not holding it tight. And put 2 fingers in the popliteal fossa and allow the pulse to come to you. Then is the posterior tibial pulse, midway between the medial malleolus and the calcaneum. And finally, the dorsalis pedis pulse. Just ask the patient to lift their first toe. Just next to that will be the dorsalis pedis pulse. So please familiarize yourself with pulses. They are life-changing to a patient with diabetes. From checking pulses, we move quickly to the ankle brachial pressure index, which can be done easily at the bedside. And the investment to have this is very, very less. Believe me, it pays itself over and over again, both in terms of healthcare as well as patient outcomes. So here we use an ordinary BP cuff. We have this handheld Doppler. It's now cost about 35,000, which easily any institution can afford. Most of our vascular surgeons, registrars will have a bag. Whether they have water or not, they'll have the Doppler, handheld Doppler in their hands. We inflate the cuff, check as we're dropping the cuff pressures, see where the sounds come. And similar one is done in the leg. In the leg, we check both the pulses, the dorsalis pedis and the posterior tibial, and we take the higher of the pressure readings, and it's a ratio. So the ankle pressure divided by the brachial pressure. This one intervention can predict heart disease, as mentioned in the Framingham heart study. Innumerable can tell you the health of the patient and the vascularity. So this is our lab where we use this handheld Doppler. Ideally, we need a leg cuff, but in our resource challenge situations, just an ordinary cuff is more than enough. This machine is 30 years old. It came when Dr. Bhushanam, who was our principal 35 years ago. After his time, it went to Dr. Sunil, and after his time, it's come on to us, and the machine still works. So it's a good investment for anyone to have. I stand on Dr. Bhushanam and Sunil's shoulders, who passed on their love of vascular surgery to me, and were very keenly involved with Nihal and Dr. Sheshadri earlier in the diabetic foot program. So what are the normal values? So the normal values between 0.9 to 1.2, 1.3 are generally considered to be normal. Anything less than that, there is vascular compromise. Anything more than 1.2, 1.3, there is also vascular compromise. And there are 2 disease conditions where you will have an abnormally high ABPI. One is in diabetes because of the wall calcification, and the second one is in renal failure. So how do we overcome this problem? we do what is called the toe pressure. This beautiful doll-like cuff over the great toe, and check the flow in the monitor there. So toe pressure has changed the way we understand. If the toe pressure is more than 60, the chance of healing is really good. If the toe pressure is between 40 to 60, it's likely that the wound will heal. But less than 40, it is critical limb ischemia. Next few minutes is you've done from the bedside, you've gone on to bedside imaging. Now let's take it one step higher and move it into the radiology realm. Now, it used to be that the arterial Doppler was only in the hands of radiologists. But now that whole practice has changed, and every specialty is using ultrasound as an extension of their arm. So it's now become point of care. It's non-invasive, very cost effective. You can learn it very quickly, and there's no aura about it. Believe me. If you can use a smartphone, all of us use smartphones. Yes, no. Any dinosaurs who don't use smartphones, you can handle an arterial Doppler easily. The next thing is a CT angio. This is more specific. It requires input. The earlier ones were tough to use, but the modern ones are so good. In fact, our mission hospital in Kotagiri has put one 16-slice CT, and they are bringing out wonderful pictures. So even small resource challenged places can do a CT scan. There are advantages and disadvantages of both, but the advantages far outweigh the disadvantages. You do need a radiographer, you do need a radiologist to interpret, and licensing has to be done for this, for sure. We can also do an MR angiogram, but again, it is quite expensive. But now, because everyone's doing it, the costs have come down, and we get very good information with an MR. All right, so we've done that. How do we manage this patient? I suspect vascular disease. I suspect the infection. Rest the foot, just elevate the foot, allow the edema to settle down. Next to osteomyelitis. Dr. Abbas, thank you for this. I can use it now in all my lectures. So he showed how probe to bone. Take an ordinary instrument, an artery forceps, and touch the base of the ulcer. Gently move it around. If you can hear this grating noise, it is on the bone. If it is on the bone, it's osteomyelitis. Maybe in a decade or so, we will have research telling us what to do with osteomyelitis. But for now, for clinical practice, if you are probing to bone, don't waste time with an expensive MRI or peptides or fancy drugs. It is osteomyelitis, and treat appropriately. So here's the algorithm that we follow in vascular surgery. Wet gangrene, pus, drain and debride. Control the infection. Assess the perfusion. If it's a dry gangrene, check for osteomyelitis and then assess the perfusion. Ultimately, it is leading, as was mentioned, that it's now become a gross surgical problem. So when we were training, we had this wonderful pediatric surgeon called Dicky Marmon, K.E. Marmon. He had a poster on his wall, and he says, when you're faced with a complex problem and everyone's scratching their heads and they don't know what to do, call the surgeon. The surgeons also don't know what to do, but they will do something about it. So here I am, and I had to, pardon my French, a bloody vascular surgeon. And this is what we do. When we diagnose that the patient has an arterial compromise in a diabetic foot, we have two options. We can either treat them endovascularly from within the vessel, or we can do a conventional open operation. In the endovascular realm, we go with wires into the vessel and open up the arteries. And the arteries that don't stay open, we'll put a internal scaffold, which is called a stent. And now we have drug-eluting balloons, which release small doses of paclitaxel to keep the vessel open. Surgery is a brilliant option. Endovascular had overtook it for a while, but people are rediscovering that with surgery, the outcomes are far longer and much better. So there are some ways of treating an occluded segment, either the normal channel, which is anatomical, or an extra anatomical bypass. Let me show you a few quick examples. Here's a patient who presented with an iliac stenosis. We put a stent and opened out this vessel. It probably takes about half an hour, 45 minutes to do this. In an earlier time, you would open the patient and do a bypass, which would take a couple of hours. But surgery has a very strong role, and we see patients, diabetics especially, who present like this, with an abrupt cutoff below the renal arteries and reformation at the groins. And in those patients, we're able to put a synthetic patch, a trouser graft, and bypass normal to normal. Now, if you notice, this patient has got a diseased superficial femoral artery. So we take the patient's same vein, great reference vein, reverse it, and restore flow to the foot. As I emphasized, most patients whom we deal are diabetics. The only 1 or 2 odd patients who are not diabetics are patients with arterial disease like Berger's disease. So it is no longer becoming a medical problem. It is very much becoming a surgical problem, and it's very much becoming a vascular surgical problem. In some patients, we're not able to recanalize. In those patients, we do an extra anatomical bypass where we take from Peter and give it to Paul. So what can be done in this room? What can be done in the mission hospitals? What can be done at a tertiary center? Check for all pulses and document it. And I must appreciate the endocrine team for documenting pulse for every patient who comes through the foot clinic and otherwise. The moment they have an infection, recheck the pulses. That is really crucial. Do an ABPI at the bedside. If the ABPI is compromised, please do arterial Doppler, Duplex, or a CT angiogram, whichever your institution is available. And please control the sepsis first. So the best thing in a diabetic foot, you get one chance. So one of the old surgical maxims are, do as much as required, but as little as possible in a diabetic foot. And please offload. So when do you call a vascular surgeon? One, if the patient has rest pain, a diabetic related foot with rest pain, with gross sepsis where you cannot feel the pulses, or you cannot hear the arterial signals in a handheld Doppler. In a patient with foot infection and no palpable pulses, please call. If there's overt gangrene, don't wait, call. You've done a debridement and the wound is not healing, call. We give a window of between 6 weeks to 3 months. If your wound is not healing despite debridement and patient is still having an ulcer, please call the vascular surgeon or refer to a vascular surgeon. If I can leave behind one take-home message, it will be, don't debride if you can't feel the pulse, unless the patient's life or limb is in threat. Most of the patients are able to come early, but if you can't feel a pulse, don't put the knife. So time for me to wind up now. And I'm glad I'm here because it's a lovely platform for us to exchange ideas among different specialties. The deadly triad of peripheral neuropathy, vascular disease, and trauma. Focus on prevention of diabetic foot ulcers. Check pulses for every diabetic foot and after every infection. Before you use the knife, use your fingers. Feel for pulses. No pulse, refer to a vascular surgeon. And if the patient has rest pain, refer to a vascular surgeon. Thank you all for your patient listening.
Now I'll call upon our next speaker, Dr. Emmanuel Lazarus. He's an associate professor in the Department of General Surgery. He'll be speaking on lower limb necrotizing fasciitis and overview. Dr. Emmanuel, please.
Thank you. And my name is Emmanuel. I'm going to talk about a particular entity that is quite devastating to a patient with diabetes and even others. And this is necrotizing fasciitis. I'm going to show you a slide that is particularly interesting. This is a slide that shows the 5-year mortality. It's published by Armstrong and others in 2020. This looks at the 5-year survival outcome for different diseases. It shows you lung cancer on one end, it shows you breast cancers, Charcot's disease, all cancers, and CLTIs also. It's very interesting that the 5-year survival for somebody who's had a major amputation is far worse than the overall outcomes for all cancers put together. In fact, breast cancer is on the other end of the spectrum. So these are not statistics that we expect, but that is the truth. And the reality is that diabetic foot ulcers and the mortality and the morbidity from a patient who's had a major amputation is very significant. In fact, it's a public health catastrophe that's just flying under the radar, waiting to happen. So in terms of the entity called necrotizing fasciitis, there are many newspaper reports that tell you that flesh-eating bacteria, rapidly spreading infections with high mortality. And that really is the hallmark of necrotizing fasciitis. It doesn't behave like the traditional diabetic foot ulcer and infection that we're used to seeing. Very early on in antiquity, Hippocrates realized that this was an unforgiving disease. He speaks about tissues falling away in a vast way, and he recognizes that there were many deaths. There's a very interesting description of necrotizing fasciitis by John Bell, the Scottish surgeon, when he spoke about one of the boys on the ship that he was traveling in, sustained a wound after a battle, very trivial, started to heal, but very quickly he became unwell, and the infection, which was just a small ulcer, rapidly progressed, and the whole skin, the whole muscles fell away, and it was quite morbid, and the boy died. So necrotizing fasciitis is this subset of skin and soft tissue infections that is characterized by a very high mortality and a morbidity. And really the problem with necrotizing fasciitis and soft tissue infections is that it's not that the treatment has changed significantly over the last 100 years. It's just that the manifestations in the early part are so subtle that it becomes very difficult to diagnose. And by the time they come, it's quite late. And in such patients, an amputation is often the only answer that you have. It's predominantly a surgical diagnosis. It's characterized by destruction of the superficial fascia, the dishwater gray exudate that you see, and a notable absence of pus. So the Americans tell us, according to CDC's criteria, they see about 700 to about 1,000 cases per year. We see about 1 or 2 patients every 3 weeks. So that is the burden of disease that we have in India, and that really reflects the volume of disease that we face. And I'm sure across the global south, this is a similar story. The mortality the Americans speak about is about 11 to 22%. We see, at least in our institution, about 50 to 60%. 1 in 5 people who have necrotizing fasciitis will die. But that doesn't mean that the other 4 who live will walk away. They will all end up with some sort of an amputation of some sort. And the morbidity in the next 5 years subsequent to that amputation is significant. So it is not a forgiving disease even for those who do survive it. So we classify it in many ways. We can talk about it in terms of the anatomy, where it's located. You can talk about it in terms of depth of infection, but effectively in terms of the microbial cause, we classify it into 2 types. There's type 1, which is the polymicrobial variety, and type 2, where you have a single organism that causes it. And there are type 2 is the commonest that we see with polymicrobial infections, and in Vellore we see a lot of gram-negative rods. In type 1, which is in type 2, which is the monomicrobial organism, we see predominantly beta-hemolytic strep, and I think that's similar across the world as well. So you may or may not have a defined portal of entry. When there is a portal of entry, you can see that there's an infection that enters through a minor scratch or a minor wound, which may be very trivial, and that enters into the soft tissue. There's local exotoxin release and a rapid progression of infection with the external symptoms of skin changes happening quite late. You may or may not have an external injury as well, in which case the findings can be very sinister and very subtle and manifest only quite late. When you see a wound like this, it's quite evident. You can see pus, you can see necrotic tissue. It's quite evident that there is something wrong, that this is a patient who needs surgical intervention. But I'm going to show you a couple of pictures where the manifestations are a lot more subtle. Here's a middle-aged man who had very trivial abrasion over both the ankles. He was managed as for cellulitis at his hometown, and he became unwell over the next 24 hours. And by the time he reached us, he was in shock. He had arrested once in the emergency department. He was on 2 inotropes, going on to a 3rd. And if you look at it, the manifestations are very subtle. And this really is the problem with necrotizing fasciitis, that the initial symptoms and signs are so subtle that it is often mistaken for cellulitis or for another systemic viral illness. And it's only very late that they actually manifest with what we think of as, this is a soft tissue infection. You see bullae and blisters and skin changes. And by that time, he's so sick that an amputation is the best that we can do to save him. So there is some edema, there is some swelling, and you can see on this image as well that there is, you can see this discoloration over the thighs as well. And they're quite subtle. You really don't expect many manifestations of pus and external infections as you would with other soft tissue infections. But there are certain signs that really tell you that this is not a straightforward infection. This is necrotizing fasciitis. Patients who present with necrotizing fasciitis come with symptoms that are way out of proportion to what you can see externally. Your symptoms are out of proportion to the sign. A profoundly sick patient with very little clinical manifestations. So often I experience that we see these patients come in, they thought it's cellulitis, or the medicine department admits thinking that there is some other systemic problem, but in fact that all you would see would be a diffusely swollen leg with some tenderness and a few blisters here and there and some discoloration over the skin. And over the next 24 hours, they progressively worsen, and then you realize, this is necrotizing fasciitis. A failure to respond to the initial antibiotic management. It's quite often, it's possible that initial cellulitis may progress on to necrotizing fasciitis. But when you see a lack of progress, suspect necrotizing fasciitis. In cellulitis, the subcutaneous tissue is often supple, and the infection is usually limited to one area. Whereas in necrotizing fasciitis, the action is happening much deeper. It's happening underneath the skin. And you have this diffusely swollen leg, which is tender and woody, hard and thick. That is not cellulitis. So these are very subtle signs, but these are the little signs that that it does afford you, that can tell you, this is not something that can be taken trivially. When you have crepitus, when you have bullous lesions on the skin, when you have skin necrosis and ecchymosis, yes, those are signs that will tell you, this is necrotizing fasciitis. If you look at this table, it's very interesting. All the symptoms that tell you, that scream out dangerous, crepitus, necrosis, induration, bullae, fluctuance, the actual percentage is very low, 0 to 31, 12 to 45%. It's quite low. The subtle signs which are often always present will be a symptom of a very sick patient, diffuse erythema, diffuse swelling, lots of symptoms, very sick, lots of pain. Those are the symptoms that you have to look for. And that really is the problem with necrotizing fasciitis. It's not that the surgeries have changed dramatically over 40, 50 years. It's not that the antibiotics have dramatically improved. It's just that it is so notoriously difficult to diagnose in the early stages. And it really, this is where we have to target and improve awareness and education. Again, there are a lot of pitfalls. They may not have fever. Many patients may have been treated elsewhere. They may have taken NSAIDs along, and you may not manifest fever. As I said, cutaneous manifestations may happen very late. You have a window where you can intervene, and that is this window. You may think that, he's had some injury before or some trivial trauma before, and that's what's causing it. But severe pain is the key finding in necrotizing fasciitis. Don't expect to find radiological or sonological findings of something sinister when you do an ultrasound or an X-ray, you may not see anything. What is notable about necrotizing fasciitis is the conspicuous absence of pus. So if I were to take a patient with neck fact and take an ultrasound point of care and screen him, all I will see is subcutaneous fluid. That's it. And I will think that this is cellulitis and I will treat him as such, but I will lose the patient. Nausea, vomiting, and the other symptoms are often the signs of the systemic toxicity, and often that's again missed. You can see in this patient over the next 4 hours how the discoloration, how the ecchymosis is spread along the entire thigh, and necrotizing fasciitis is typically characterized by its rapid spread. You have an infection that starts in the foot and it goes up not in days but in minutes to hours. So you can have a patient who has come to the emergency department in the morning with soft tissue infection around the ankle, and by the time you revisit him in theater 4 hours later, it's crossed the knee. So that is really the speed at which this infection travels. And I can show you this. I can show you, for the lack of time, I will skip some of the images, but effectively what you do realize is that patients may not have many external symptoms, many external signs, and most of the infection is lingering deep below. If you do an X-ray, you may see a few air foci here and there deep inside, but again, don't use this as a tool to identify necrotizing fasciitis. It is a clinical diagnosis. You can do a CT. It may show in late stages if there's myonecrosis or extensive soft tissue infection, extensive destruction. But every minute that you spend not taking this patient up for a fasciotomy and achieving source control, it is time lost. There are certain scores that were proposed by Wong et al. To look at necrotizing fasciitis to see if you can predict whether it's there or not, but mostly it is better, these are better used to rule necrotizing fasciitis out rather than rule them in. The mainstay of necrotizing fasciitis management is surgical. They are quite sick and they do need to be optimized in an ICU setting, but it's important to note that the treatment for necrotizing fasciitis being surgical, don't waste time in the ICU resuscitating, because the treatment is the removal of the sepsis. It is the amputation or the debridement, and keeping the patient in ICU, antibiotics and trying to bring his BP up will not really help until you get the source of infection out. So we use a combination of meropenem and clindamycin. This is our hospital infectious diseases guidelines, which we follow. So it's predominantly a carbapenem with clindamycin with an addition of MRSA cover if required. And once we have established that this is a monomicrobial infection, then we switch over to group A streptococcus if indicated. So if there is infection, if there is a suspicion that this is necrotizing fasciitis, take the patient to theater. The earlier you achieve source control, the sooner, the higher the chance that this patient is going to improve. If the patient is in a small center, the earliest that he can go to a location where he can have his source of sepsis taken out, the better. Effectively, you would want to do a fasciotomy, since most of these patients do not have external symptoms suggestive of cellulitis or soft tissue infection. A fasciotomy is diagnostic. You can identify whether there's involvement of the fascia or pus deep to it. And once you do confirm that, you will have to go ahead and achieve adequate source control. And often in these cases, most of the time it would be aggressive debridement, or unfortunately, in most of the patients who present to us, there is often some sort of an amputation. And as Dr. Prabhu mentioned, it would be to a level where you have good vascularity. There are 3 zones. One is the zone 1, where you have the obvious infection that you can see. Zone 2 is the area of infection that is deep to the subcutaneous tissue, which you can't see, which you do need to address. And zone 3 is where you have healthy tissue. So you do need to address all the infected tissue, which is including what you can see as well as what you can't see deep below the skin, to ensure that your source control is adequate. So classically, you see this loss of resistance to fascia, there's dishwater or foul smelling discharge, there's a lack of bleeding, there's necrosis, and a conspicuous absence of pus. So the delay in surgery is usually what causes the mortality. A serial debridement, if you think that you want to try and salvage the limb, if possible, try it, but most of the time, an amputation is probably the most likely chance that you can do to make this patient survive, and it is often the best source control. So the wound care is critical. Once you have source control, you must ensure that you continue to address the wound and ensure that there is adequate clearance of the infection. In such patients, don't expect the dressing to do your job. You will need to do debridements at the bedside to ensure that you remove all infected tissue. If you find tissue that is infected, must redebride. You may need to do serial redebridements. Multiple visits to theatre is not a failure. It's expected. Pain management is very important to ensure that you have good wound assessment, and good analgesia is very critical. These patients are in a highly catabolic state, and you do need to ensure that you correct for these things. They often have a lot of other problems associated with it. The sepsis in itself pushes them into sepsis-induced cardiomyopathy. They're often in inotropes. They're often in acute kidney injury. They're often in DIC. And see, these patients often have other issues that need to be addressed as well. By the time we think about these problems, then we consider that the battle is almost won, because if you're worrying about this, then we're very happy about it. Remember that necrotizing soft tissue infections and necrotizing fasciitis is a very notoriously subtle disease. It's very similar to cellulitis. Early necrotizing fasciitis doesn't look sinister. The symptoms are out of proportion to the signs. If you have a sick patient, signs very little, symptoms quite a bit, diffusely swollen leg, tenderness, pain beyond the obvious region, diffuse erythema, suspect necrotizing fasciitis. Take the patient up to theatre for an early diagnostic fasciotomy. Surgery is the diagnostic tool. There is often a reticence saying, should I really need to take this patient up to theatre if I suspect necrotizing fasciitis? A fasciotomy is diagnostic, and you do need to do that without hesitation, because a delay in that decision would mean the difference between this patient living or you realizing 12 hours down the line that, oh, he's on 3 inotropes and now we can't really do anything. So early aggressive surgery with radical source control is key to saving lives. And really, if there's more education on the ways necrotizing fasciitis can manifest in the early signs, in the early symptoms, that really would be the cornerstone to achieving some sort of progress over this disease. If there are any further questions, I'll take them. Yeah.
Now I'll call upon our next speaker, our colleague Dr. Felix Jebasingh. He'll be talking on primary prevention of foot ulcers. It's not that straightforward.
Yeah. So we all know this gentleman who was here was none other than Paul Brand, and I was actually mentioning about in the past few minutes back that diabetes is nothing but modern day Hansen's, is because whatever offloading or whatever we are discussing is actually based on the research which was done in Hansen's disease in the past, and we are all actually reaping what was sold way back almost 30-40 years back. So it's actually a teamwork. If in terms of prevention itself, it's a teamwork because everybody has a role in prevention. And so I would say it's a teamwork which we are continuing here. I'll show probably 3 cases and say how we can probably prevent a foot ulcer in terms as a primary care physician or a surgeon who sits in the outpatient department. So this is a straightforward patient who comes for glycemic control to any physician. You can see the patient has no ulcer in the past. This was a photograph of the patient. You can see this patient came to the outpatient department in Chittoor, where we had a secondary healthcare setup where we run our OPD twice a week. So this was taken from there a few weeks back. You can see this gentleman walks barefoot inside the cabin where we were sitting. So that itself is a simple education you need to give. Please don't remove your footwear when you come inside any of the outpatient rooms. That itself is a simple education to prevent a foot ulcer, because many times that itself a cause for the foot ulcer. And you can see, if you closely look at, you can see there is clawing in the toes, and also you can see there is a bunion which is in the verge of developing, etc. But it's not clear in the picture. But so this is a classical pre-ulcerative state. We are talking about all the sequelae of ulcer, which is actually ends up with a probable amputation or a major surgery, morbidity and mortality. So in the guidelines itself, it suggests that this is a pre-ulcerative status. Just a preamble about why this pre-ulcer is important is, a patient with diabetes and foot ulcer, they have a rapid progression of renal disease. This is evident even in an Indian study done by Vijay Vishwanathan in Chennai. So it is actually a rapid progression of the renal disorder, which is much more than that of patient without a foot ulcer. So that is why it is important to prevent a foot ulcer rather than having a foot ulcer and try to treat it, because if the patient has foot ulcer for 5 to 6 months, there is an increased growth factors, and that itself is a detrimental to the kidneys. So that is a very straightforward pathophysiology causing a renal failure. So when we walk, we all have a various forces, which is horizontal and the shear force, which normally happens. But unfortunately, in patients with diabetes, they have a peripheral neuropathy, which is motor as well as sensory as well as autonomic dysfunction. It actually overlay all this and have a abnormal pressure points if they're all sets in together. So that is why we need to understand about the prevention of foot ulcer when a patient comes for diabetes evaluation, and not only for a foot ulcer, for any evaluation comes to OPD. Let's say a patient may be in the wards, has admitted for a myocardial infarction. Patient may be admitted for a cardiovascular other events, which may be in the ward. So there itself, I can see a lot of nursing staff sitting here who can actually prevent a foot ulcer with just a simple education. When we talk about the modern evidence, we always talk about guidelines. Are we actually talking with an evidence-based method where we have a systematic review or a meta-analysis or a guidelines which actually puts forward and say that there is an evidence? So what I am talking is basically in line with the International Working Group for Diabetes 2023. And so it's simple. When anyone who comes to the outpatient for diabetes evaluation, or maybe having any macrovascular disease, having diabetes, the simple is inspection, palpation, and percussion. It's simple, straightforward, what we have learned in our MBBS days, and also then other allied health sciences. You know that this is easy to look at and just diagnose. And the modern gadgets are just to add on to make sure that what we see is actually true. So you can see this is straightforward intertigo, which can develop into probably an ulcer and amputation. So what we need to remember is we need to probably make sure that we diagnose all this early and take care of it adequately. So to line up, you can see this all we know: a dry skin, fissures, callosity, corns, intertigo, malato, hamato, and all the other pre-ulcerative status we all know, and we would have seen in our outpatient, though maybe having an ulcer in one side and the opposite foot may be having this problem. To make it little more understanding, just to inspect the skin, you can find a lot of diagnosis. You can prevent a foot ulcer looking at the bones and the deformities associated with the diabetes related patients with diabetes. You can also probably prevent foot ulcers. And obviously nails have been a very neglected area, which many a times source for a future infection, because the patient tend to cut the edges, the patient tend to get a hit on the while walking, and the nail bed injuries leading on to infections. So I just briefly go through the fewer systematic reviews, what they talk about in terms of diabetes and this particular pre-ulcerative status. Dry skin, most of the times we think that it's simple because it's a dry skin, but it's a autonomous dysfunction. If the patient has a ant bite or a mosquito bite, they tend to scratch and they develop an aberration, and that developed into a cellulitis and sequelae. But interestingly, there is no clear consensus of what exactly need to be used. But however, the simple straightforward is use any moisturizing cream which is available in the market, and that would be serve the purpose. Very important is most of us, we tell the patient to use coconut oil, but unfortunately this attracts ants and also rats, which will develop into a ulcer later on. As Dr. Abbas already said, he has seen more than 400 patients with rat bite. We regularly see patients with rat bites and ant bites, and in the outpatient, when we ask a leading question, they say coconut oil being applied, and subsequently they had this problem. Fissures, we all know fissures, it's straightforward, but what are we doing about is need to be educated to the patient to look at the fissures daily, for such that there is no signs of infection or inflammation going around, and giving a 6 or 12% salicylic acid will generally cure this problem, and daily foot examination should be educated. You can see in the right side, you can see the gentleman has a callosity in the lateral malleolus. This is nothing but because of the cross leg, where the patient is an accountant who sits in the shop continuously for 12 to 16 hours and try to complete his daily work. So the simple education is to sit in a small stool or use a sponge beneath the lateral malleus, and especially praying position, they can have the pressure points which could be abnormal, but you can see that this all just beneath that is the bone, and which can develop in osteomyelitis and amputation. Intertigo, very common in Indian subcontinent. Just looking at the web space can prevent simple intertigo by using an antifungal cream, and this can be a route of entry for a bacterial infection. That's the main story here, because the fungal infection is not to kill the patient, it is the fungal infection which breaches the skin, which allows the entry of the bacteria to enter, which causes cellulitis. And you can see, if you closely look at, there is a subtle cellulitis around that area with a bit of a darkish skin around that, which is actually developed a little bit of gangrene also. So you can see that it's actually a patient with intertigo and impending cellulitis. So these all are pictures which are taken from the foot clinic as well as from the outpatient clinic, which we see in regularly in endocrine department. So cons is, we all know cons, and we tend to use our knives or tend to use nail cutters with a hook and try to pull it out. All this thing, it has to be educated to the patient not to do that, and get a surgical assistance to make sure that should be good. But remember that, as Dr. Prabhu said, that important to just palpate the pulses before doing anything in outpatient, because simple paring and it'll be enough. That means just removing the callosity itself will cure. Fungal nails needs means a long-term therapies, because if you see fungal nails, it grows irregularly, and it tend to get infected when they hit against the edges of the doors, or maybe while walking they hit against an object. That nail tend to break very fast, and then to have a paranoia and also subsequent ulcer and amputation. But most of the time they need a KOH mount to diagnose exactly what is the fungal infection in that, and needs a longer therapy and need a good liaise with dermatology department. Ingrowing nails, again a major problem. We all know that ingrowing nails, I've seen people using the nail cutters to try to cut the edges, and this all need to be educated to the patient to prevent a foot ulcer, because interestingly, equal amount of responsibility is on us to diagnose, especially fissures, intertigo, and patient need to be educated about how to take care of their nails, because most of the patient, if they are not being educated, they tend to come back with the foot ulcer, and which could have been the amputation. The other very important is barefoot walking in a religious place. This is a recent photograph taken from an outpatient, where the patient went for a walk in a temple and come back with this exactly pressure point, can have a scalded injury of because of the temperature out there are 45 degrees when the patient was walking around in a temple. You can see this is a simple education. Just wear a temple sock, which is available freely in the market. In fact, nowadays we are advising the patient to walk, use this as a sock to use within the house itself, because most of us have a cultural taboo not to use footwear inside the house. So we are educating our patient to use this as a add-on to their regular footwear. If they are not allowed to use a footwear inside the house, to use a sock with a, it's nothing but a silicone insole within, or some of the sock has a MCR rubber which is fixed in the outer part of the sock. Another important is there are cultural practices which itself can probably cause for foot ulcer, especially toe rings. When you have to understand, if the patient wears toe ring, it's not against anything, but remember that there is always a risk of tight toe rings causing foot ulcer. You can see here this lady had osteomyelitis of the third toe in spite of having a toe ring, and also you can see the third picture, can see there is a tight toe ring causing a foot ulcer. So other thing is bunion and hallux valgus. This all needs a close follow-up and care. If the patient is able to use some gadgets, you can use it, which will be I'll be showing in a couple of other slides. And especially when there is a clawing, it's not about the plantar aspect, it's about the dorsal aspect also, as a friction in the footwear which we prescribe, which itself can cause foot ulcer, which could be a pre-ulcerative status if you look at closely. Tight shoes, educate the patient not to use a tight shoes, which can cause crowding of the toes and can cause overriding of the toes and abnormal pressure points, not in the plantar aspect, in the lateral aspect of the foot, which can cause foot ulcer. So what do we do about this? We have spoken about, we all know about all this condition which we would have seen everywhere, even in our families. We may be having one of this, which I shown in the slides. But what are we doing about this is, when there is a foot ulcer with pre-ulcerative status, if you look at all the pre-ulcerative states, especially the bony deformities, it's all in the forefoot. It's not in the midfoot or in the hind foot, because if there is any deformity in the midfoot or hind foot, it goes towards a shock-out foot. It's not straightforward pre-ulcerative status. So you can see this is a gentleman who came a couple of months back to us with a simple callosity. Look at that he has hematoma. This itself is a pre-ulcer. If you don't remove it, it's just a culture medium. Whatever we are culture medium uses a blood agar. It is a culture media to just have a infection and proceed further, probably have an amputation also. And you can see he has already have an amputation in the past, and it's almost 7 times high risk to get one more amputation in the next 5 years time. So other major findings which we in our clinic also, when there is a callosity, they tend to have a foreign body within the callosity. We have seen a lot of patients having stones or maybe glass pieces or earrings. We have seen earrings when we debride, there is a stud with inside the callosity. So we have seen all this because the patient has probably stepped over it and never had pain and concealed within that and have a callosity over it. So, but remember that whatever you are doing, please check the pulses before touching that, paring the skin, so that things will be there. So what do you think about this foot ulcer? Anybody just want to volunteer, PGs? Which, when a patient comes to your OPD, you look at only the foot which is having a foot ulcer. That is what our eyes goes. But look at carefully, the opposite foot has a callosity and a fissure. So this is what the primary prevention is all about. So we always tend to deviate from our focus because our focus point is the ulcer, and we miss out on the opposite foot, which is actually high risk. So it is a high risk foot, not the ulcer foot. It's actually the opposite foot. You can see the callosity and the fissure, where this callosity, if there is a good pulses, might need a paring or a keratolytic agent, and that fissure, which is really in the abnormal area and needs a 6% salicylic acid. The other very important is when it's have a callosity, we have a practice in our foot clinic to do an X-ray for all the patients with callosity. You can see this gentleman, actually, when we did a X-ray, we can see there is a destruction already happened. In spite of there is no foot ulcer, there was a callosity. When we removed, there was an ulcer beneath. So this is a story that X-ray is major player in terms of doing before pairing, because this gentleman had an underlying ulcer beneath, and he was given 6 weeks of antibiotic. He's is cure and in remission. In terms of insole, I'm not going to the detail of it. There are a lot of insoles available. However, I'm not going to detail because it's a greater discussion. But however, whom to prescribe a footwear? Everybody in patient with diabetes should be prescribed a footwear. It's not about patient has neuropathy or no neuropathy, even because what we use monofilament is 2 gram, not the 10 gram monofilament, which has been given by the guideline. We use 2 gram monofilament to make sure that we diagnose a neuropathy much earlier than what it has been prescribed, so that we find out 2 gram monofilament, which is not being used for Hansen's disease. We use it widely, not the 10 gram, to make sure the neuropathy is. We want to give them a footwear for these patients so that we prevent a foot ulcer or make sure that they are not having a passport, so that we stop at that one. So now all this, so when you look at the guideline, they talk about 2 things in addition. One is toe devices and other is surgical offloading. I'm not going to the detail of it, but however, you need to understand that they clearly mention that please give adequate footwear for everyone who has a deformity. But if they have a recurrent of all this, wisely use surgical offloading or a toe devices appropriately. So it's very clearly mentioned in the guidelines. All these devices, I'm just going to rush in a little bit to show and sensitize you that there are a lot of toe devices available in the market, very easily available. If you go to any online marketing forum of your choice, you type whatever I'm showing in the next slide, you will get it in no time, because nowadays ambulance comes faster or not, this devices comes faster, right? So that's how the story is. So toe separators, bunion shields, you can use wisely in your patients, but remember that all has to be educated, because this has to be used with a sock. Because if you don't use with a sock, what will happen is it slips off. So this can be given provided you use adequate, appropriate footwear, and the patient still have recurrent foot ulcers. Instead of giving all this, then use this wise. And all toe cap, toe props, metatarsal pads. In fact, this particular toe separator comes in skin color also, and different colors where patient may be happy to wear also, but remember that the patient need to wear with a sock. So what I'm showing is a guideline which is being put forward by the International Working Group for Diabetic Foot 2023. We are modified after a greater discussion within the department and found that probably we need to tailor-made a little bit for our Indian subcontinent, probably to certain other countries as well. You can see all the deformities are in the forefoot. So anterior rocker is nothing but whatever footwear we are using here, you all have an anterior rocker. Exaggerate the anterior rocker to 8 to 15 degrees, but individualize depending upon the patient. Mobility, BMI, height, all this plays a major role, because that probably collapses the anterior rocker quite a lot. So you need to individualize. If in spite of using that particular devices, a particular anterior rocker, and have a recurrent foot ulcer, or you can go for a surgical offloading or a toe devices. Just to highlight, there are a lot of toe devices available in the market. You can use wisely according to what the patient you are looking at. Could be a claw toe, hammer toe, could be toe separator for a crowding of toes, where you can have right now have toe separator for 2 toes, 3 toes, all the toes together. Different colors are available in the market. So you can actually use wisely, but however, don't forget opposite foot. That's very, very important, because if you don't take care of that, patient was going to come back with foot ulcer. Simple foot ulcer prevention is all about inspection of the foot as well as the footwear, because footwear itself, if there is a worn out footwear or there is a thorn or a nail embedded in the footwear, that itself can cause a foot ulcer. So that is very, very important. Individualize the footwear, not same for everyone. Simple treatment like salicylic acid or maybe a moisturizing cream will prevent definitely a greater degree of foot ulcer and the amputation. Thank you so much for patient listening.
Our last speaker for the day is Mrs. Bharti. Bharti is a diabetic educator. As you would know, those who are familiar with how the diabetic foot clinic works and endocrinology works, They are, I would say, the backbone, and they really take up the mantle of doing this difficult work of educating patients, the foot care, and they do a lot of work in terms of early prevention and management of the foot. Bharti, over to you.
Good evening, one and all. So the last talk for today is going to be on secondary prevention of ulcer. It's what you wear. Without further delay, we will move on to the topic. So we all know diabetic foot ulcers are very complex and chronic problem, and it actually really needs an integrated approach. So that's what is followed in our integrated foot clinic. And the basic key of treating diabetic foot ulcer is to offload the diabetic foot ulcer. So the basic thing what we do is, when the patient comes with diabetic foot ulcer, offloading is taken as a very important aspect. So we try to relieve the high pressure area by ensuring that an appropriate footwear is given for the patient. And I would like to start my talk stating that prevention is always better than cure, because as what Dr. Felix sir has told, there are many important key factors to identify the problems in a very early state, so that patient doesn't move on to the part of secondary prevention of diabetic foot ulcer. So to ensure, these are the cornerstones of diabetic foot ulcer prevention, where we need to identify the risk foot. We also should be regularly inspecting and examining the foot. And once we identify the problems which are creating to be an high risk problem, treat the risk factors for diabetic foot ulceration, ensure that a proper footwear is given to the patient. And as healthcare professionals, we need to be educated and updated as well. So this picture depicts that these are the areas which are at risk of developing diabetic foot ulcer. So when we look at the picture, the forefoot plays a very major role, where most of the pressure is predominantly placed. And you all know, in the toes and in the metatarsal head, there are more pressure areas, and in the midfoot and in the hindfoot as well. But predominantly for diabetic patient, because patient has loss of sensation going on, they have weakness of the muscle, and then they've got muscle wasting which is going on, they predominantly place more pressure in the forefoot area. And we commonly see forefoot ulcers in our diabetic foot patients. So due to time constraints, I'm not going to discuss about all the high risk areas, but few cases would be discussed, and what are the best offloading measures we can give for our patient. So this is one of our patients who had come with a chronic diabetic foot ulcer. So she had a foot ulcer in the third metatarsal head, which was going on for months together. So, but by looking at the ulcer, it's a chronic one without any infection. So the best key for treating the diabetic foot ulcer is, we need to make sure that the area of ulcerated area which is coming in contact with the ground level has to be offloaded. So what we try to do is, so these are some of our patients who come with diabetic foot ulcer in the forefoot area. Now the first offloading key which we are going to emphasize is like what we are treating the patient with. So this is something called as using an anterior rocker. So this is called as MCR with anterior rocker. So usually what happens is, when we normally walk, okay, we try to place our heel, the midfoot comes into contact, and then we try to place more pressure in the toes to push away from the ground level. So for a normal person like us, we will know how much amount of pressure we need to place when we have to push the toes away from the ground level. But for a diabetic patient, because the sensation is lost and the muscles are very weak, they will not be able to know how much of pressure they are going to give. So what happens is, they are going to give excessive pressure when they are going to push the toes away from the ground level. And when a patient has these kind of active diabetic foot ulcer, what we are trying to give is, we are trying to give a rocker where there is a mild angulation in the forefoot area. So when this angulation touches the ground level, immediately there is a smooth rocking motion from the toe to the heels, and thereby there is pressure reduction in the forefoot area. So this actually gives us a better result in wound healing. But this is applicable when the ulcer size is like literally less than 3 centimeter. The MCR with anterior rocker is applicable. Yes, this is one of our patients who had come very recently with MCR with backstrap. So what we try to do is, because this patient was not willing to change the existing footwear and the ulcer size was very small, we have given an option of giving him a scooping. Scooping is nothing but, like say for example, the point of contact, like say patient has got an ulcer in the first metatarsal head. So we try to scoop the area in the first metatarsal head. So when the patient places the foot on the footwear, the ulcer doesn't come in contact with the ground level, and this also helps in better wound healing. So this is a very, very simple cost-effective measure where like anybody can be like some leather technician or somebody who is trained in doing this would be able to do this in a very better way. So this is MCR with scooping. And one more cost-effective method of offloading is placing a metatarsal bar adjacent to the foot ulcer. So say for example, patient has got an ulcer in the metatarsal head. When the metatarsal bar is placed adjacent to the ulcer, so when the patient tries to walk, the metatarsal bar is going to hit the ground level first, so that the point of contact on the ulcerated area is taken care. And again, this helps in better wound healing. But again, there are kind of restrictions when we try to give the anterior rocker. When the ulcer size is going to be really very big in the forefoot area, or the ulcer size is like in a close proximity to the midfoot, then we have to entirely offload the forefoot area. So what we try to do is we give something called as an anterior ortho wedge. So this is how the difference is between an anterior rocker and an anterior ortho wedge. So what happens is in an anterior rocker, there is a smooth angulation which comes, but in an anterior ortho wedge, the 1/3 portion of the weight bearing area is totally taken off. So when the ulcer size is going to be very big, this anterior ortho wedge helps in better wound healing, because 1/3 of the contact is not going to be placed on the ground level. But the problem with the anterior ortho wedges, because 1/3 of the portion is not there, patient really will have some amount of instability while walking. So that is when the physiotherapist help the patient to teach the patient how to walk with these kind of walking footwear. I mean, with these kind of offloading measures. And when we make these kind of footwears, we place extra pieces of leather on the footwear so that the anterior ortho wedge or the rocker is made. So always we need to make sure that the opposite foot, there is also eye correction done. Otherwise, there will be instability when the patient walks. So this is a picture of anterior ortho wedge. So moving on to the next case. This is a patient who had come with a dorsal aspect ulcer. So usually for dorsal aspect ulcer, we can like go with a normal MCR with backstrap. But what really happens is when we go with a normal MCR with backstrap, these straps can overlie over the ulcer, and this can cause some amount of friction over the patient's skin when they try to walk. So to offload the area, what we really do is we give something like an iron offloading device with a strap modification, so that the straps doesn't overlie over the ulcer. Or the other important offloading device is called as a surgical shoe. So this is very, very important. We use it like a multifactorial purpose, like patients who have undergone a ray amputation or a greater toe amputation, or patient has got the ulcer totally healed. It is very easy for the patient to wear with the surgical shoe. So any patient, even with a dorsal aspect ulcer, these kind of surgical shoes can be better prescribed. The drawback of the surgical shoe is this is made up of a polycotton material, so it doesn't withstand for a longer period of timing. So maybe once in 3 to 4 months, they need to change these surgical shoes. And this is one of our patients with transmetatarsal amputation who had come to us. So these are the series of photographs which shows the progression of the foot ulcer. So for offloading during the initial phase, we actually given them the offloading method of using a crutch or a walker to completely offload, and plus a surgical shoe. Surgical shoe was modified according to the shape of the foot which was remaining. So offloading with the surgical shoe was helping him, and with a good offloading with a surgical shoe, and for the affected foot with modified surgical shoe, and additionally with a walker, patient was, we were able to have a better wound healing within 4 to 6 months of timing. So this is our patient with post transmetatarsal amputation. They were able to cope up and the wound healing was much better. And then the final case scenario for today is going to be on Charcot foot. So Charcot foot, again, it's a very, very complex disease problem of patient who has developed diabetic foot problems. So it is a condition where the patient has got weakening of the bones and the bones tend to fracture and the foot takes actually an abnormal shape. We usually call it as a rocker bottom deformity. So once the patient sits in with a rocker bottom deformity or with a chronic Charcot, when the patient comes to us, we look at the offloading measures, what could be best given for them. Because once they set in to have a problem, usually the deformity doesn't reverse back. So we try to give a footwear so that whatever deformity the patient has come with, we try to preserve the deformity and further progression of the deformity can be prevented. So before offloading, we assess the ankle joint stability. If the ankle joint is stable, so we give something called as a molded insole. So this is called as a molded insole. So what we try to do is when they make the footwear is made according to the shape of the patient's foot. So when the patient walks, the foot and the footwear will not be two separate units. It will be acting as same single unit so that the pressure in the vulnerable areas or the pressure in the high risk areas would be taken care. So this is MCR with molded insole has to be given when the patient has got chronic Charcot foot deformity, and we have to keep in mind that the ankle joint position has to be stable. And if the ankle joint position is unstable, we do use something called as a pneumatic boot walker. We have got two options for that. We actually use ankle foot orthosis. It is actually a custom made one. It needs expertise in doing it. Also, we have a commercial model, which is what I'm showing you. This is pneumatic air boot, where the air is inflated and it tries to immobilize the foot and ankle together and keeps the foot in proper position. And because it is commercially available and it has got nice Velcro padding, which is nicely kept in, patient prefers to go with this and it is very comfortable for the patient as well. So to end up, I would like to state that always prevention is better than cure, and patient has to be educated on foot care. And first of all, we need to try to tackle the predisposing factors for diabetic foot ulceration, and we have to ensure an appropriate footwear is given all the times, which will lead to improved compliance, and this will lead to prevention of foot ulcer and its recurrence. Thank you so much.